All right, everyone. Well, it is 12 o'clock on the dot, so let's go ahead and get started. Good afternoon, everyone, and welcome to our Department of Medicine Grand Rounds. My name is Ryan Abe, and I'm one of your inpatient chief residents, and I'm here with my co-chief, Dr. Tess King. Today, I have the pleasure of introducing our speaker, Dr. Monica Vela. Dr. Vela is a professor of medicine at the University of Illinois in Chicago, and she serves as the director of the Hispanic Center of Excellence. She previously served as the Associate Vice Chair for Diversity and Associate Dean for Multicultural Affairs at the Pritzker School of Medicine. She spent the last 16 years directing a required course for first-year medical students entitled Health Disparities, Equity, and Advocacy. It provides a structural competency foundation in advocacy training. Her coursework is the only course in the extant literature shown to improve diversity of medical school applicants and improve the cultural climate among medical students. Her research spans medical educational health disparities, care of patients with limited English proficiency, and diversity in the medical profession. In 2014, she was awarded the SGIM National Herbert Nickens Award for Diversity and Minority Health. We're so excited to have her here to join us today on the last grand rounds of Black History Month to talk about institutional racism in medicine and our role in ending health inequities. As a reminder, please post your questions in the chat. Dr. King and I will pose them to our speaker at the end of the talk. So without further ado, I will turn over the floor to Dr. Vela. Thank you for joining us.
Thank you, Dr. Abe, for that wonderful introduction. I am honored to be with you and even more honored to have been selected to speak during Black History Month. I'm going to go ahead and share my screen. Let's see, make sure I get the right one. There we go. And the title of my talk is Defining Institutional Racism in Medicine and Our Role in Ending Health Equities. I have no disclosures, sadly, none at all. And this is what we're going to do today. We are going to define institutional racism. We'll be applying Dr. Camara Jones's theoretical framework of institutional racism, and then identify the institutional racism that's deeply embedded in our history of medicine and the practices in the medical profession in both education and training. I love to make sure that I put pictures up of the people that I am quoting or referring to. And this is a definition of institutional racism from Dr. David Williams. He writes that institutional racism refers to the processes of racism that are embedded in our laws, local, state, and federal, our policies and practices of society and its institutions, including the profession of medicine, that provide advantages to racial groups deemed as superior, while differentially oppressing, disadvantaging, or otherwise neglecting racial groups viewed as inferior. One of the reasons that I love his writing is that he makes it very clear how such a complex process could happen implicitly and explicitly. He gives racial segregation as an example and also as a fundamental cause of institutional racism. So racial residential segregation, which was supported by federal and state policy and creates an other, a group that is now separated, reduces access to quality education, reduces access to employment opportunities, concentrates poverty, allows for disinterest or divestment, leads to elevated exposure to physical and environmental hazards, such as inadequate housing and higher levels of contaminants in soil and water, and also reduced access to resources that actually enhance health, like green spaces, exercise facilities, and healthcare facilities. This is an incredibly important cause to understand because it is a root cause of institutional racism and allows people to recognize how this can become embedded in our practices. It is also really important to note that these policies were not only created by federal and state governments, but supported even by institutions. So I can tell you that at the University of Chicago, from the 1940s to the 1960s, the university poured hundreds of thousands of dollars to make sure that the neighborhoods around the university were kept predominantly white. How did they do this? They did this by purchasing tenement homes and then upgrading them to the point where most people could not afford to live there. They did this by supporting contracts that kept any people of color from being able to purchase homes in the area. And so it's not just our federal and state policies, but institutions that contribute to this racial segregation. Camera Jones writes that institutionalized racism is supported by 6 basic principles: an initial historic insult, structural barriers, inaction in face of need, societal norms, biological determinism, and unearned privilege. And what I'm going to do now is walk you through how the profession of medicine supports each of these and evidence for each of these within medicine's history. So medicine has in its complicity an initial historic insult, scientific racism. We can look back and see such examples as Dr. Samuel Cartwright, who wrote, "Negroes have a disease that made them insensible to pain when subjected to punishment." And as far back as 1916, when Lewis Terman, author of The Measurement of Intelligence, wrote that intelligence was not only hereditary, but directly correlated to morality, crime, and poverty, especially referring to Spanish, Indian, and Mexican families of the Southwest, and also among Negroes. This statement, which was really taken in by most of our institutions, in particular the federal and state government, allowed for, between 1920 and 1945, under California's eugenic sterilization program, approximately 20,000 people were sterilized in California state institutions. Most of them were Hispanic and Black. Our complicity in allowing for these processes in medicine and even supporting them and touting them has served as the basis to historic and modern eugenics and white supremacy movements and differential treatment on the basics of, quote, scientific truths, end of quote, that allowed for slavery, inhumane research practices, and forced sterilizations. We also created structural barriers, and we did so through the AMA, through the Flexner Report, and through the segregation of hospitals. We know now, and it's been well documented, that the AMA was actually challenged after the Civil War repeatedly to address its discriminatory practices. But the AMA decided to absolve its own self of the charge of racism and instead admitted 2 all-white delegations and excluded the sole integrated delegation in 1870. By 1874, under increased pressure, the AMA decided to turn this issue around. It created a state-based federation out of the AMA, and the impact was significant because most state and local societies were already racially exclusive. African-American physicians were effectively excluded from the AMA. Keep in mind that this occurs over 20 years before the Supreme Court ruling in Plessy versus Ferguson. This is where I want to pause and walk away from the repeated insult of hearing about what the AMA and others did to maintain segregatory practices and talk about people who rose above those practices. Because I want to make sure that we understand that despite oppression, people did rise. And so it's important to note the history of Alexander Augusta, who was born in Virginia, desperately wanted to become a physician and applied to UPenn. UPenn rejected him on the basis of his race, but he was accepted at the University of Toronto. He did incredibly well there, returned to the United States, but was rapidly rejected by the AMA. He was, however, accepted into the 7th U.S. Colored Infantry, and became the highest ranking Black officer in the Union Army during the Civil War. By 1863, the United States had established, America had established Freedmen's Hospital, and he became the first African-American head of a hospital. Freedmen's Hospital was opened by the War Department. It was meant to serve as the first military hospital for Black veterans because Black veterans could not receive care at other hospitals where white people were receiving care, and later served emancipated refugees. However, please note that it was always open to all people in need. Freedman Hospital went on to become Howard University Hospital and a major hospital for the African American community in Washington, D.C. Another person who rose was Dr. Charles Drew, who trained at McGill Medical School. He was the first Black surgeon examiner of the American Board of Surgery and revolutionized medicine by creating a system that allowed for the immediate and safe transfusion of blood plasma. During World War II, he recruited 100,000 blood donors and saved the lives of thousands of wounded soldiers, both Black and white. Ironically, the U.S. Armed Forces maintained a segregated blood donation system and refused to give blood from non-whites to white soldiers. The National Medical Association was established in 1895 in direct response to African Americans being excluded from the AMA. Dr. Robert Boyd was the first president, and Dr. Daniel Hale Williams served as vice president. Their mission was to combat racism and segregation, something we are still on the path to doing. The NMA is an incredibly important association and grew rapidly over time. As you can see on the right, they started with 15 members in 1905 and grew to 2,000 members in 1928. In 1950s and 60s, they did a lot of work to promote the medical civil rights movement. They also established the Journal of the National Medical Association, which is near and dear to my heart. And it is near and dear to my heart because in the early days of my career in medicine, when I was publishing on issues related to racism and segregation, the JNMA was a wonderful home and one of the few journals that was accepting articles about racism and segregation in medicine. We'll move on to discuss the Flexner Report, which I'm sure you've heard an awful lot about already. You may already know that this report was published in 1910 by Abraham Flexner, and the goal was to revolutionize and standardize medical education in the United States and Canada. Now, when I was a medical student and as a resident, we had a yearly grand rounds dedicated to Abraham Flexner and to his work in revolutionizing medical education, but we never heard about chapters 13 and 14 in his report. Chapters 13 reviewed women's medical education, and as you know, Abraham Flexner traveled across the United States and Canada, visiting every medical school and making recommendations. Regarding those schools that were dedicated to the medical education of women, he wrote, "The motives which elsewhere would recommend separation of the sexes would appear to be without force." And he wrote that intern privileges must be granted to women on the same terms as men. He recommended closure of all women's medical colleges and supported that schools be integrated. While this sounds wonderful, what actually happened is that women's medical colleges closed and very few women were actually accepted into other medical schools. In chapter 14, he wrote about Negro medical education and recommended that the practice of the Negro physician be limited to his own race, that Black people be served only by Black physicians, and that Black physicians care only for Black people. He also wrote that Negro doctors should be trained as sanitarians, which is the common term back then for public health official, not surgeons, so not physicians. And he wrote this because he felt that the most important issues to address at the time for the Black population in the United States were actually tuberculosis and syphilis, both of which he wrote could be dealt with by public health measures and should be dealt with by public health measures because he did not want them to spread to white populations. He wrote and recommended the closure of most African-American medical schools except for Howard and Meharry. And this next sentence always startles me, and I call your attention to it because he wrote that those schools should be closed, though admittedly, they will be unequal to the need. And so when I'm challenged on Abraham Flexner, when I'm told that he could not have anticipated the harm that he had done by recommending closure of these medical schools, I point to this sentence. Because it is true that he traveled across the United States, that he knew the distance from Howard in Washington, D.C. and Meharry in Nashville, Tennessee, and recognized that there would be whole swaths of this country where African Americans lived and would not be able to seek care, that there would not be enough African American physicians to care for everyone here in the United States. Going back to the AMA, you may be asking yourself, if there was an NMA, why did African Americans need the AMA? And I'll make it clear that AMA membership and hospital privileges were tied to each other. Most hospitals required that staff be members of their local medical society and or the AMA if they were to have hospital privileges. And because specialty training takes place in hospitals, board certification defines those medical specialties, and bars to societal membership in the AMA were also bars to specialty training and professional advancement. And so in 1931, out of the 25,000 specialists in the United States, there were only 2 who were African American. And I want you to close your eyes and just imagine what it must have been like to be African American in the 1930s and 40s and 50s and 60s and not be able to find a Black specialist. I also want you to know that this slide always gives me pause because this picture of Daniel Hill Williams reminds me what one person can do in their lifetime. Daniel Hill Williams was heralded as a Moses in the medical profession. He was born in 1856, entered Chicago Medical College in 1880, interned at Mercy Hospital here in Chicago. And if you know anything about Chicago, you know that we are in a great deal of pain right now because Mercy Hospital, which was one of the first hospitals opened here, recently closed. Mercy Hospital cared for a great number of populations that were underserved, under-resourced, and underinsured. And its closure during COVID has created chaos for the medical system in Chicago. And other hospitals has been inundated and unable to care with any degree of quality for the populations that were left without service. Anyway, Dr. Williams eventually founded Provident Hospital in Chicago, which was an inpatient facility for Black patients. At that hospital, he was able to train Black nurses and Black medical school graduates. And in fact, the University of Chicago, who at the time had 2 Black male medical students who had reached their 3rd year and were ready for clinical training, and who were unable to receive that training at the University of Chicago because they were unable to care for white patients. Those students were sent by the University of Chicago to Provident Hospital for their clinical training. I want you to know that in addition to those achievements, Dr. Williams also was responsible for the first repair of a penetrating spleen wound in 1902 and a second repair of a stab wound to the pericardium. First successful repair of the pericardium in 1893. He, as I mentioned before, was chief of surgery at Freedman's Hospital, opened Provident in 1891, and also created a surgical training hospital program at Freedman's Hospital. And so this slide, again, always makes me pause, because I think if one person can do so much and advance the medical profession so far, what were we missing, and what have we been missing by excluding so many other people? And what advancements would we have today if we had not done so in our history? Back to the AMA. The AMA continued to rebuff any attempts to change their discriminatory practices all the way up until 1963. Now, typically, this is when I turn to my audience members and I ask them to imagine what would induce the AMA to change their practices. And someone always shouts out money. And they are always on the money, because it was not until the passage of the Civil Rights Act and the passage of Medicare, when by threatening to withhold federal funding from any hospital that practiced racial discrimination, Medicare forced the desegregation of every hospital in America virtually overnight. And I usually keep a picture here of Grady Memorial Hospital because of its two towers. It was well known that Grady maintained one tower for white hospitals and one tower for white patients and one tower for Black patients. And quite literally overnight, and there are some images of this, white patients were moved from one tower to another, and Black patients were moved from one tower to another to end segregation and make sure that they would not lose any federal funding. So when did the AMA apologize? Sadly, the AMA did not apologize until 2008. And I think apologies are incredibly important. Apologies allow for institutions, for organizations, for governments to say, we are going to stop. We recognize the harm. We are going to change our practices. We are going to remind ourselves what we've done, and we are going to make sure that this does not ever happen again. And so I actually believe that every institution has an opportunity for contrition, for reconciliation, for collaboration, and for doing better. It will be shocking to some, but not to most, engaged in medical education to recognize that the enrollment of Black men in medical schools has fallen since the 1970s. And that Black people account for less than 4% of medical school faculty members. It's not shocking when you know the history, and it's not shocking when you understand that with institutionalized racism comes such practices that are so embedded in everything that we do, in the way that we teach, in the way that we train, that this is difficult to reverse, right? So it's not like moving people from one tower to another. It requires everybody to be on board and to make change happen. So let's talk a little bit about inaction in the face of need. This is where I give examples about medical deserts, which we all know are areas where there's not sufficient access to vital medical resources. This is where I like to stop and think about how we distribute those resources, and how rural residents, Black city residents, and Indigenous peoples residing on reservations experience such inequities in health. Not in any part because of their genetics, not by choice, as I was taught in medical school that there must be some element of choice here, but in fact due directly to the impact of medical deserts and the distribution of resources. And I'm sure that you've heard about our trauma deserts in Chicago and those that exist in LA and New York City, and how people are treated differentially. There's inaction in the face of need that is also insurance mediated. And a lot of this has to do and goes back to occupational segregation. When people are employed in occupations with high turnover rates, they are much less likely to have insurance that remains intact when they lose that employment. And there continue to be many states with large minority, rural, and uninsured and low-income populations who have chosen not to access the benefits offered by the ACA. And so there continues to be an insurance coverage gap between white people, Black people, and Hispanic people. And this does not need to happen. This needs to change, but we continue to support this system. And this is part of our continued complicity in creating inequities. Fourth is societal norms. And so we've come to accept our insurance policies. We've also come to accept that there is significant implicit bias amongst providers. To this day, if you interview providers, you will find that there's a prevalence of anti-Black and anti-Hispanic bias that ranges anywhere from 42 and 100%. Now, I recently conducted a systematic lit review of explicit and implicit bias amongst providers. It was incredibly painful because there were over 7,000 articles to review, but also incredibly painful because I found that not a lot has changed. In a national sample of US medical students, 81% of heterosexual respondents reported holding anti-gay or anti-lesbian implicit bias. Several studies continue to demonstrate an association between that bias and a lower quality of care for patients belonging to any number of minoritized communities. And you can ask yourself, what does provider bias have to do with quality of care? A lot. One of the studies that actually made the hair go up on the back of my neck demonstrated that patients are as good as an implicit association test in designating which providers hold a high level of implicit bias. Imagine a patient is able to tell by the way a provider speaks, by the language they choose, by how quickly they come in and out of the room, by whether they listen actively, whether that provider holds bias for some identity of that patient. And it's as good as an implicit association test. What has been further demonstrated is that when patients identify that bias, they are less likely to return to see that provider, and they are also less likely to follow through with the therapeutic plan provided by that provider. So implicit bias becomes incredibly important when it comes to quality of care. This is another way that we continue to support implicit bias. This is a recent study done at the University of Chicago, documenting racial bias in the electronic health record, right? So Black patients were had a 2.5 times odd of being described with one or more negative descriptors in the history and physical in the notes of the EHR, even when correcting for socio-demographic and health characteristics of that patient. Patients with Medicaid and Medicare also had higher odds. This raises a concern about racial bias and the transmission of stigma in the medical record, right? So if I am a provider and I'm seeing a patient who is new to me but has a record at my hospital, and I read notes that describe them as non-compliant or describe them as difficult, there's no way that I'm not going to develop some implicit bias about that patient. It is also true that we should be very concerned that patients are now able to access open notes and read about themselves and read the language that we use to describe them. Because again, it's going to lead to patients not trusting their providers when they use that language and making decisions about whether that provider is actually providing the best level of care for them. There are countless numbers of studies demonstrating the impact of implicit and explicit bias. This is another study that raised the hair on the back of my neck, a study demonstrating lower rates of post-operative narcotic prescriptions for Black children compared to white children after an appendectomy. After an appendectomy. I'll say it again, children. It really takes hold of you when you read some of these studies and you begin to recognize that we have a lot of work to do. We see this complicity as well in our biologic determinism, both in medical education and in political practice, and how we've chosen to uphold calculations of eGFR that are different for Black patients than for white patients, pulmonary function testing with reference values that are different and are adjusted for race and ethnicity, even pediatric urinary tract infections diagnoses have a coefficient that varies according to race. What about unearned privilege? For this, I'm going to ask you to turn to NIH funding and think about the fact that award probability for Black PIs is 55% that of white PIs of similar academic achievement, demonstrated in the early 2000s and demonstrated again in the late 2000s. That we see disparities in publications by race, a lack of diversity in editorial teams and among peer reviewers, in the leadership of journals and of medical societies. I also want you to stop and think about NIH funding and how it gets distributed in this country, and consider the case of cystic fibrosis and sickle cell disease. Keep in mind that there are more patients with sickle cell disease, in fact, 2.5 times more patients with sickle cell disease in this country than patients with cystic fibrosis. And yet, when we look at the NIH funding per person, we see that there's a greater amount going per person with cystic fibrosis than for patients in the study of sickle cell disease. How can this be? How can this be true today? Is it because there is a racist person at the NIH handing out the funds? It is much more likely that it is because money begets money, and that because private donations to cystic fibrosis research are much higher than private donations to research regarding sickle cell disease, and because research regarding cystic fibrosis, due to that amount of greater funding, has been much further ahead than the advancements made in sickle cell disease, that the NIH is much more likely to grant funding to someone studying cystic fibrosis and see the possibility of success in that research than they are to research that is related to sickle cell disease, right? The layers upon layers of decision-making that come when money is distributed inequitably need to be undone. What about you all? What about our trainees? A 2014 systematic lit review revealed that rates of harassment and discrimination against trainees have remained unchanged over time, with similar results in 2019. And more specifically, that 24% of trainees report racial discrimination, 33% report sexual harassment, and 54% report gender discrimination. We should also keep in mind this slide, which I'm going to ask you not to share on social media because it has yet to be published, but will be published soon. This slide came to me by Dr. Bill McDade, who has spent his entire life addressing diversity and the lack of diversity in medical education and in training. He was appointed as the ACGME's first diversity officer just 3 years ago. I'm going to say that again so it sinks in. The ACGME did not have a diversity officer until about 3 years ago. He quickly went straight to the data and unearthed this, that there is something happening in the rates with which we dismiss residents by specialty and by race and ethnicity. And you'll quickly see that there are some specialties that are dismissing Black and Latinx house staff at a much higher rate than white residents. We don't have the reasons, but the results are so dramatic that we have to stop and agree that this has to be multifactorial, that this must be complex, but also that there's something racial going on here. And we need to dig deeper. This is one of my favorite studies conducted by Dr. Derby, because it didn't leave a whole lot of question in my mind. Dr. Derby followed over 3,000 medical students as they went on to become resident physicians, followed them for 7 years, and they were surveyed periodically for measures of burnout, which was defined as emotional exhaustion and depersonalization, as well as explicit and implicit bias towards Black people. What her team found was that resident physicians with burnout had greater explicit racial bias and implicit racial bias against Black people. Resident physicians with burnout had greater explicit and implicit racial bias, right? This says a lot about what we are doing during training and how we're treating our resident physicians, right? Because how we treat our medical students, our residents, and our providers directly impacts how we treat our patients and whether we are supporting bias. So I want you to imagine yourself as this person here in the center. You are being taught racialized medicine. You experience in your medical school, in your training program, on the wards, and in every other setting, a limited amount of diversity because we don't have enough representation amongst our physicians at every level. You experience high cognitive load. You're making decisions that directly impact the quality of life of your patients under significant time pressure. And I know that most of us have gotten a lecture or two about RVUs and finishing our clinical notes on time. And you are also working in a biased learning and work environment. So here you are feeling all of this and being taught all of this and experiencing everything that comes with it. And you see a patient here on the right in the blue, a patient with hypertension. And you say to your patient, you have hypertension. I'm going to educate you all about it. I'm going to give you these 2 prescriptions to go out and fill. I want you to go out and reduce the salt in your diet, increase the fiber in your diet. I want you to explore some healthy green spaces. I want you to get plenty of exercise. And I want you to then come back and see me in 6 weeks' time. And the patient comes back and you check their blood pressure, and lo and behold, they've got a normal blood pressure. And you say to yourself, wow, I'm a really great physician. I made this happen. And what a great patient. And the patient confirms to you that you are a great physician, and you're walking around and you're feeling good. And you walk into the next room and you see a patient also with hypertension here on the left. And you give them prescription for 2 blood pressure medications. And you provide education on lowering salt and reducing stress and accessing green spaces and exercising. And the patient goes out and they find they cannot afford one of the prescriptions you provided, and they're having difficulty accessing healthy foods because there's a paucity of fresh food sold in their neighborhood. They are unable to exercise because, believe it or not, there are many less places to exercise in areas of increased poverty. And they return to see you and their blood pressure is not well controlled. And you say, I know I'm a good physician. Must be something wrong with the patient. And all of a sudden you're experiencing confirmation bias, right? We have many reasons for that bias to be difficult to eradicate, as I've explained throughout this lecture. Unfortunately, it will lead to poorer health outcomes for your patients. And so I'm going to charge you with recognizing health equity as our ethical and professional responsibility. And I'm going to charge to you to recognize distributive justice, which proposes that institutions, processes, and structures be allocated in a manner that seeks to improve the well-being of the least advantaged in society. I'm also going to charge you to recognize this principle that argues that it is our collective responsibility to ensure that those being placed in harm's way are prioritized and protected. And guess what? That includes our medical students and our trainees and our faculty. And so when I started at my new job, and I had a clinic both morning and afternoon, and new patients were being placed into my schedule at 20 minutes a clip, and they were complex patients with complex lives, limited resources. I wrote a letter. Despite the fact that I had only been at the institution for a few weeks, and I said, "Dear director, section head, and department head, I can do one of these, but not both. I can provide the best care possible to this patient, given our resources, or I can provide the best possible care in 20 minutes, but I can't do both. And so I need you to explain to me what we're doing, having new patients seen in 20 minutes, and how we can move forward to make this better." And so I'm going to charge all of you, whether you're a medical student, a resident, or a junior faculty member or a senior faculty member, to think about distributive justice and this principle as you move forward through your day, and ask, in what ways are you being prioritized and protected, and why it's important for your care to be prioritized and protected, because it's the only way that we are going to create a situation that reduces our time pressure, our cognitive load, that we can begin to address this biased learning environment and tackle racialized medicine and limited diversity. I'm going to stop there.
Amazing. Dr. Vela, thank you so much for such a thoughtful presentation with such important takeaways for all of us as physicians. For the audience here, please, if you have any questions, let us know in the chat. At this point, I will start off with a question, actually. I'm curious, Dr. Vela, if you have any thoughts about how healthcare institutions who work within larger societal institutions can sort of work within distributive justice, things like payment structures, local and state laws, those things kind of interplay with each other, and how can we advocate for those things at larger levels?
Yeah, so I remember not too long ago, a very prominent physician wrote an article stating that academic medical centers cannot be responsible for the care of the communities in their surrounding areas. And I kept that article because it raised my blood pressure. I can only imagine if we had held to that, to the teachings in that article, how COVID would have been addressed or not addressed in present day, right? There is just no way for us to move forward and say that we are delivering a high quality of care, that we are caring for our communities, without recognizing that our communities are at constant risk from forces outside of the hospital. There's no way for us to move forward and say that we are good physicians that we as a medical profession are putting our patients first without recognizing the social and structural determinants that put their health at risk. And so I think we need to recognize our role in activism. I think we need to recognize that if our local community is being challenged by a factory spewing out toxins, if our local community is being challenged by a higher degree of violence and that is impacting the health of everyone in the community, we need to become engaged. We need to rally against that factory or help our public health officials to recognize what our community members are experiencing and get those dollars to come in and have the policies changed. It is how here in Chicago we managed to keep a factory from moving from the north side to the south side of Chicago, where there's already a greater amount of pollution being experienced by residents.
I love that. I think we all have a huge role in advocacy at that level. That's really, really important. Another question that just came through the chat. Are there any things, like a couple of things that you have implemented in your own clinical practice that you recommend us to do sort of as individual physicians to improve care on the patient level?
Yeah, so that reminds me of something that happened, maybe it was about 8 months ago. I belong to a wonderful practice of 30 physicians, very committed people. And like most primary care physicians, we are being challenged to maintain our quality metrics. And it was very clear that we were making gains on some quality metrics, but not others. We were having our routine monthly meeting, and a hospital administrator came to the meeting and said, good news. We are going to implement a bonus system for those physicians who have the best quality metrics on their patients. And I thought about this for about 30 seconds before jumping in and said, hold up. There are those of us who have been practicing here for 30 years, who have patients that we've been seeing consistently for a couple of decades. And it's taken us that long to get those quality metrics in place for them. And then there are those of us who are junior faculty who are coming in and seeing new patients. And it's going to take a couple of decades to get their quality metrics in place because we're working with a very limited resourced patient population. So who's getting the bonuses again? And the longer we sat with that question, the longer we realized that we were advantaging senior faculty and disadvantaging junior faculty. And in fact, we walked away from the meeting saying, we'll be back. We're going to look at our data a little bit more because we know how to do this. We looked at our data and found that actually the least resourced patients were not only being seen by junior faculty, they were also being seen by physicians who identified as underrepresented in medicine. So the question came up again, who are we giving our bonuses to? Right, and so we walked back into our next meeting and asked the hospital administration to withhold our bonuses. And we told them that we wanted all of that money to go into hiring an additional social worker to work with our patients, an additional social worker who would be dedicated to working with our least well-resourced patients. And so there are points in time where you might be shocked, where you might have a question, where you might wonder, is this an equitable practice? And you have to stop the clock, ask the question, review the data, and then come back to the table and decide where the resources should be and how they should be allocated.
I love that. There are so many examples in medicine where resources are allocated to those who are already privileged. And so I love that sort of like stop and think about your practice and how you can reallocate those to the people who need them the most. That's
right.
Great.
And these algorithms that we create are often going to be our downfall. Another example at our hospital is that one of our quality metrics person developed an algorithm for deciding which patients we needed to discharge faster and what we could do to help them get discharged faster. And it was things like bring their prescriptions up to the bedside, make sure that their family was at the ready to pick them up and drive them home, and incentivize them to get moving once they were discharged. And what we found when we actually put the algorithm to work was that our least resourced patients, again, were missing out on all those additional privileges because they didn't have someone to come and pick them up. And they didn't have assistance in getting home. And so we actually did away with the algorithm and used those resources to provide taxis and Ubers and buses to get our least resourced patients home.
That's great. Shifting gears a little bit, in terms of medical education, do you have any thoughts about how medical schools and medical training programs can start to sort of undo all of the historical ways that folks of color have been kept out of medical training and the profession of medicine in general?
Yeah, so it has to start at the top. So when the leadership of the institution or of the school says this is a priority, that's when things happen. Right. And so you will find that change happens much more quickly when the leadership decides that everybody needs to be on board. So number one is having the leadership make a very clear statement about prioritizing these issues and about resourcing, addressing these issues. The second thing is to teach the faculty, right? So very often we are teaching our medical students all about institutionalized racism and equity, and they are well-spoken and they know the research, and then they go to the wards and their heart drops to their feet because they recognize practices that are not equitable, and they hear language that is anything but just. And they are in the position where they feel powerless and even feel like they might suffer if they intervene. And so I say, let's educate the faculty who are teaching and hold them to a higher standard, and not teach from the bottom up, but from the top down. And so I think it is in our best interest to teach our teaching faculty and our clinical faculty on these issues so that they don't uphold unjust practices and they don't lose the faith and trust of medical students who have already decided this is going to be my role model, right? The third thing then is to take the time to go through what we're teaching and find what I love to call opportunities to make it better, right? The fourth thing is to put in a very straightforward reporting mechanism so that if I'm a medical student sitting in class and I'm seeing that my beloved faculty member is talking about beautiful babies and showing that all the babies and all the pictures are white, I should be able to very easily pull up a link and say, I would love for my beloved medical educator to change his slides and make the pictures more inclusive. End of story, right? And for that, then recommendation to be routed to the dean of curriculum, to the dean of diversity, and to the faculty member. And for that faculty member to be resourced to be able to change their slides, to change their language, to change the mechanisms they have in place. And allow for that to happen as a teachable moment, as an opportunity, and then move forward with everyone else. It needs to be simple. It needs to be straightforward. And it needs to be seen as an opportunity.
That's great. And just want to take a moment to plug our bias reporting tool that rolled out a couple of years ago here that we have. And I think I love that advice. I think it's so poignant for our not just medical students, but all of our trainees here. Another question is, we have a lot of people from different specialties who are listening in. Are there any guidance or steps that you'd recommend for residency and fellowship programs and sort of promoting a diverse group of trainees in their programs as far as the match and things that we prioritize as institutional training programs for what we're looking for in applicants? Any ways to rethink that?
Yeah. So I think the number one thing is that love starts at home, right? So when I send out my medical students and residents to apply at different institutions, I say how well cared for, how mentored, and how loved are the people at the institution now. Don't promise me something for the future. Don't show me how you're going to treat me. Demonstrate to me that you are caring for the people you have in place now. And then I will get the message that you are also going to care for me, that you are also going to love me, that you are also going to make sure that I'm going to thrive with everything that I am, right? And so I think making sure that the people you have in place now feel that, they feel that they can thrive and do well is the biggest determinant of whether you're going to be able to build a more diverse medical school, residency, training program, fellowships, and faculty base.
I love that. Love starts at home. That's great. All right, we have a couple more minutes left. If anyone has any other questions, please feel free to post them in the chat. Otherwise, we could end a little bit early before the end of the hour. But I wanted to thank Dr. Vela again for such an excellent talk and her just ultimate wisdom and all of the experience in this field. We have a lot of work to do as an institution.
Thank you for the invitation. It's been an honor. I wish I could see all of your faces because I get so juiced up by seeing people's faces and expressions. But hopefully we will be in touch in the future and have opportunities to interact some more.
Absolutely. All right, everyone, have a good afternoon. Take care. Bye.
Thank you again. Bye, everyone.